Yeah. All right. I think you guys can see my slides. Can everybody hear me?
Yep.
Awesome. Okay. Yeah, so my didactic today is taking a sexual history, and I wanted to start with the poll because initially I was going to do a poll question asking if anyone on the call had taken a sexual history on anybody in the last year, but then I figured this group is pretty engaged in HIV prevention because this is the HIV prevention echo. So I didn't think that was a fair group to poll. So that was why I was asking about yeah, everyone's personal experience and if you've been asked as a patient any sexual history questions. And I thought by saying any, that would kind of set the bar pretty low, but it seemed pretty in line with what the national statistics are, is that we aren't being asked about sexual history. So hopefully today, this is my first time giving this talk. And so at the end, I'll definitely leave time to open up a conversation if anybody wants to have one. But if anybody has any tips or strategies or anything else that they, stories that they want to discuss, I think that's also useful for the group as well, rather than, me just talking about my experience. So, um, first, we'll start off with the definition. So, sexual health is defined by WHO as a state of physical, emotional, mental, and social well-being in relation to sexuality. It's not merely the absence of disease, dysfunction, or infirmity. It encompasses a wide range of topics, so includes knowledge about anatomy and function, sexuality, sexual identity, sexual orientation and gender, reproductive health and fertility, and sexual violence. So it's not just related to how likely it is that you're going to have a sexually transmitted infection, but really covers the breadth of all of these issues. And it can greatly impact overall quality of life. So it's a key part of all of our health, and everyone should have a pleasurable and satisfying life as a sexual being in whatever capacity that means for them. But unfortunately, it often does get overlooked or deprioritized, even I should say. So our role in the healthcare field is to really provide to our patients a proactive and our clients a proactive, integrated, and patient-centered approach. What we don't know what we don't ask. So if you're not inquiring about sexual history, then how are you going to find out if anybody is having any issues to where we can offer interventions? We should really, offering sexual, you know, discussing sexual health provides us as providers with valuable information about our patients' behaviors. It allows us to perform appropriate testing at appropriate times and appropriate sites. It allows us to tailor our counseling and provide the right interventions. And then also, sexually transmitted infections are a public health issue. If anybody's looked at the news, you see syphilis is on the rise and is at highest rate since 1950s, which is incredible. That came out with in 2022, that data. And so it's definitely something that we need to tackle at a community level. And so, really, if you don't feel comfortable necessarily at this point in discussing specific sexual health questions, hopefully I can help you through that, or at least some of that today. But, really, I think a good approach to start with is going to just be discussing it as part of routine healthcare. And so not just saying, well, we've got other things to talk about. We'll kind of just put this on the back burner, or maybe somebody else is going to talk about it. It's going to be an uncomfortable conversation if you're not used to it, but it gets easier with practice. And if you, really just aren't in a place that you're quite yet ready to ask the specific questions, just offer opt-out screening. Just say, hey, I offer STI testing as part of my routine health maintenance. And, you can always talk with me about this, or we can screen you more frequently if you'd like, but do it more as an opt-out approach rather than, really targeting who you're offering testing to. Most STIs are asymptomatic. And so you're, just like if you are checking blood pressure routinely and you find out somebody's hypertensive, then you're going to start asking more specific questions and tailoring your management, you're not going to identify patients that would benefit from STI testing unless you kind of just look for it to start with. And so the literature shows that, and all of these, we'll send out the PowerPoint slides after the session today, but all of these are links. So if you wanted to go to the articles afterwards, you're more than welcome to. But literature shows that sexual history taking practices are inconsistent, which is pretty obvious. So again, you know, the poll we did, there was, what was it, Kelly? 79% were not asked.
Correct.
Yeah, and so it's really varies. So for just overall healthcare providers at a routine health screening, it ends up being, or like at well visits, that sexual health history, this is a study from '06, but that they are really only asked, you know, 30% of the time. Any sexual health question is going to be addressed. And then if patients present with STI related concerns, even those patients are really only going to have discussions about their sexual health anywhere from 8% to 82%. And that's not helpful at all. So there's such wide variability on who we're asking and how often we're asking and those types of things. And I think some of that comes from our own biases. So unfortunately, you know, we try to do our best, but sometimes you kind of glaze over certain patients. If you know they're married, you might not ask them questions. Being married doesn't mean you're not having sex or not having sex with other people. If they're elderly, we may kind of miss that. And, you know, it doesn't matter what age you are, you can still be sexually active. And so, you know, it's something that we really need to be just offering this to all of our patients. Sometimes even we perceive that sometimes sexual history taking might be received by our patients in a negative manner. And so again, that shouldn't matter. It's our job to be having these discussions. And so the more you feel confident in this, the more frequently you're going to be having these discussions and offering screening. And honestly, there was also a study in 2018 that said patients actually prefer active inquiry about sexual health issues from their clinicians. They don't want to have to bring this up at their visit. They want their provider to offer it. The good thing, and actually I just finished clinic this morning and had a med student with me, and I asked her, you know, how are they doing with sexual history taking in their curriculum, and I was really impressed. They're really doing a lot of what we'll talk about in this didactic today. So things are getting better, but you know, certainly with my age group, we didn't have any type of sexual history taking curricula. So, and then lastly, you know, competing interests and clinic demands. Obviously, we're always time limited with our patients, and so this can also contribute to difficulty in making sexual history taking a priority. So where do we start? You know, kind of obvious, but create a welcoming environment for all of your patients. So it should be when they set foot in the door. It shouldn't be, you know, you shouldn't be the only one offering this. Again, with time limitations, there's an average of 18 minutes that a patient spends in the waiting room before they're seen by the provider. And so you can offer as part of their, you know, intake forms or updated health forms, have sexual health questions on that form. And then if you need to expand further when you see them, then at least you have that basic information. Certainly asking consent and ensuring confidentiality is appropriate. Try not to interrogate the patient, just have a conversation. Try to minimize, you know, note taking. We shouldn't be typing on the computer every single thing that you know, they tell us, especially with sensitive questioning such as sexual health history. And then really try to normalize sexuality as this is just routine health. This is just part of you. Open the door for patient questions. De-emphasize risk. Don't focus on like how many partners have you had in the last 6 months or years, because that can sometimes make patients uncomfortable. You've either had no partners, you've had one partner, or if you have more than one. To me, it doesn't matter if you've had 3, 6, or 25. It's still my management is still gonna be similar. And so just an example, I talk with all my patients about sexual health. It's part of your overall health. And like the rest of our visits, this information is kept in strict confidence, unless you or someone else is being hurt or isn't in danger. Do you have any questions before we get started? Just a way to open the door. Avoid judgmental and stigmatizing language. So using open-ended and affirming language. Let patients know that you respect them and that you don't assume anything when it comes to their sexual and gender identities. And you can also, have that information on your intake form as well. Allow patients to understand that you're going to be receptive, whatever their response is, and that you're there to support honest communication and to identify areas that they're doing well in terms of sexual health, and that things that maybe you can help with interventions that may maximize their wellness. Also, making sure that we facilitate identification of vaccinations, necessary testing, and then, make sure that this is individualized. And these all kind of seem pretty, common sense. But I will say that even though we want to avoid judgmental and stigmatizing language, I don't want you to get hung up on language and terminology to where that's where your primary focus is. And I'll talk a little bit more about that as we go through the standardized questionnaire or approaches that are available. So the most popular standardized approach to taking a sexual history is called the 5 Ps. And this is released as a CDC guidance. And so this was actually released with the 2021 STD treatment guidelines. And this is great because they really, I think, did a pretty good job of making this standardized and trying to not make it focused on quantity, but more quality of sexual activity. So the 5 Ps refers to partners, practices, protection from STIs, past history of STIs, and pregnancy prevention. So partners, to assess risk, we want to know the number of partners. Now in the CDC, 5 Ps recommendations, this document says that you want to know number of partners, gender of partners. Again, I don't think that is as important as understanding what types of sex your patient is having with their partners. Because again, it's important to know, are they cis? Are they trans? Are they having sex with cis, trans, non-binary? I don't want to say you need to ignore that because that's important to your patients. But don't focus on trying to keep that all straight in your head. Are they having oral, vaginal, or anal sex? Are they having sex with a penis? If they're having sex with a penis, then they're going to be at a lot higher risk of sexually transmitted infections than if they're just having oral sex. So try to focus more on what types of sex they're having, what parts they're using, and where they're putting them, than you are saying, do you have 2 partners? Do you have 20 partners? Are they male? Are they female? Are they trans? That doesn't matter as much, okay? Don't ever make assumptions about sexual orientation or gender identity of the patient or their partners. Certainly ask about risk factors such as other concurrent partners, past sex partners, drug use. So even with, with my poly patients, there's a lot of diversity even with that. So somebody can say, I can have 2 different patients that are telling me that they have 4 partners. On one hand, I could have a polyamorous relationship where there's constantly open communication that's ongoing. They're maybe not using condoms, but they're all getting tested for STIs regularly. They all are open and honest, and it's a closed loop. That's not going to be worrisome to me in terms of sexually transmitted infections as somebody that's having sex with 4 anonymous partners. So even then, like I said, number of partners itself is not as important as knowing what types of sex. And these examples I provided were straight from the CDC, but like I said, I have a little bit different rationale for why my approach is slightly different. You might also want to say, instead of partners, may also want to say people you're having sex with, because sometimes people think of partners as relationships, and they may not be in relationships with the people that they're having sex with. So sometimes even that kind of verbiage can matter. So practices, the second P, this is going to guide your assessment of patient risk reduction strategies, determining necessary testing, and identifying what anatomical sites we need to collect specimens for STI testing. And so this goes in line with partners, and these are kind of specific. Do you have genital sex? Do you have anal sex? Are you the insertive or receptive partner, or both? Or I usually just say top, bottom, or switch. When you use oral sex, are you using condoms? How often are you using condoms? In what situations do you use condoms, or what situations do you not use condoms? Do you ever meet partners online or through apps or that you don't know as well? Do any of your partners use drugs, or do you use drugs? Do you use them before sex? Do you exchange needs, sex for any of your needs? And again, this doesn't have to be an interrogation. This doesn't have to be a one and done where you ask this very intensive sexual health history at one visit, but just kind of get used to asking basic questions, and then based on what they're telling you, you can expand further. So the third P is protection from STIs. So what measures are you and your partners taking to avoid STIs? This gives you an opportunity for education. So condoms aren't the only way, to avoid sexually transmitted infections, but let your patient kind of tell you what they're doing, and then, be positive in terms of these are the strategies they're already taking. How can we protect them further? If you use prevention tools, what methods are those, and how often are you using these? A lot of my patients, they'll use condoms for anal intercourse. Few of my patients tell me that they're using it for oral. A lot of my patients will tell me if they've, feel like they know the partner, whatever that means for them. They may not be using condoms. So, kind of gauging what is their threshold for when they're using prevention methods and not. Vaccines, again, asking if they've gotten HPV, Hep A, Hep B shots. Asking, have you ever heard of PrEP? And have you ever used it or considered using it? Are you aware of DoxyPep? If they're cis male or transgender woman having sex with men, DoxyPep is a great tool. Have you ever used it or considered using it? And then prior STIs, this kind of sometimes gives you an idea of if it places your patient at greater risk now. If they've had, chlamydia when they were 20 and now they're in their 50s and they've been mutually monogamous with their significant other for 30 years, okay, then I don't worry about that. But sometimes, if they've had 3 STIs in the past 6 months, okay, I probably want to be asking these questions more frequently. So have you ever been tested? Would you like to be tested? Have you ever been diagnosed with an STI in the past? Did you receive treatment? When was this? Any symptoms that keep coming back? What about your partners? And were you tested for the same STIs that they happen to be diagnosed or treated for? Do you know your partner's HIV status? Just kind of those questions to explore a bit further. And then the 5th P is pregnancy intention. So you might determine that your patient or their partner could become pregnant. And so you want to know what they are doing if they are not intending to get pregnant, what they're doing to avoid it and what information they may need. So what are your current plans? What are your desires regarding pregnancy? Are you concerned about your partner getting pregnant or yourself getting pregnant? Are you trying to? How important is it to you to prevent pregnancy? And then are you using any type of contraception or practicing any form of birth control? And would you like to talk about ways? So the other standardized history taking approach is referenced as the goals framework. And this was developed and released in September of last year. So this is fairly new. It was developed to better meet the needs of patients by not solely focusing on risk, which I do like this approach. Although I feel like the 5 Ps is a great starting point. I think that we can just maybe tweak the verbiage a little bit. But the goals framework is designed to streamline your sexual history conversations and elicit information most useful for identifying an appropriate clinical course of action. So this is really the goal of this is to reimagine their sexual health history taking to make it easier and more productive for both providers and patients. This was developed in response to 4 key findings for sexual health research literature. Number 1, that just universal, so opt-out testing and biomedical prevention education is more beneficial and cost-effective than risk-based screening. Number 2, this emphasizes benefits rather than risks and is more successful in motivating patients towards prevention and sexual health care behavior. It also allows for positive interactions with healthcare providers to promote engagement in their own prevention and care. And this was another study that I'd alluded to in the beginning, but patients want their providers to talk with them about sexual health. So this goals framework was developed to address these. Sexual health history can be awkward and unfamiliar. It doesn't always provide accurate or useful information for patient care. So when you're using those standard risk assessment questions, like with the 5 Ps or even just in general, sometimes they can be alienating to patients. Sometimes they can discourage honest disclosure. And sometimes they can communicate that the number of partners or their actions is the only component of sexual risk and health that you as a provider are concerned about for them. So examples of this, asking, how many lifetime partners have you had? How many times have you had anal sex with a man and not used a condom? Those are probably not the best way to gauge open communication with your patient, nor does it really matter. I don't really need to know how many partners you've had in your lifetime. Again, I really care more about what your behaviors are now and what parts you're using. And asking, well, how many times in your life have you had sex with a man? I don't care. You can have anal sex with a woman. So it's just kind of trying to tweak that, reframe those conversations a bit. Rather than seeing sexual history taking as a means to an end, this goals framework considers the sexual history taking process more as an intervention that's going to increase rates of routine testing, increase discussions about prevention and contraception education, increase motivation for and commitment for positive sexual health behaviors, and then also kind of gives you some leverage to have your patients feel comfortable coming to you with any specific sexual health concerns. The goal itself, so goals framework, it's 5 steps. The G, give a preamble that emphasizes sexual health. O is offer opt-out HIV and STI testing and information. The A is ask open-ended questions that help you identify the aspects of sexual health that are most important to the patient. And then mirror the language the patient uses to describe their own body, partners, and sexual behaviors. L, listen for relevant information and fill in the blanks. And then last is S, suggest a course of action. So offer HIV testing, 3-site testing. So oropharyngeal, rectal, urine, or urethral gonorrhea, chlamydia testing, PrEP education, contraceptive counseling, unless any of that testing is specifically negated by what the patient tells you. So if they're not having anal sex, you don't need to, swab their rectum. And so an example with that would be if the patient's already told you that they're a gay man with more than one partner, you don't need to ask their number of partners or their HIV status, partner's HIV status, to offer PrEP and offer them HIV and STI testing. If you keep kind of harping on those very specific things, it may end up causing the patient to be kind of more defensive. If they're giving you enough information for you to offer an intervention and it's not going to change your management at all, then don't focus on it anymore. A little note about adolescents. Part of sexual history taking, this is part of a broader risk assessment, and it should include addressing issues related to homeschool, substance use, tobacco use, etc. It should be appropriate for their developmental level. Important to interview the teen alone, and again, reinforce confidentiality. And then care needs to be taken when introducing sensitive topics like sexuality with teens. So an example of a conversation you could start with is, I'd like to ask you some questions that are important for me to help you be healthy. Anything we discuss will be completely confidential. I won't discuss with anyone, not even your parents, without your permission, unless you or someone else is being hurt or in danger. You could also say, some of my patients that are your age have started having sex. Have you ever had sex? And then if you've identified that they are sexually active, then you can go ahead and proceed with a more complete history taking. And then the 6th P, which actually you could probably keep going and come up with more P's too, but 6th P would be prepare for additional questions. So they might come up with questions to expand on further. You might even say at the end of the discussion, is there anything about your sexual practices that I need to know to ensure I'm offering you the best care? What other things about your sexual health and sexual practices should we discuss? What are your concerns about your sexual health? And then also consider, asking about sexual functioning, pleasure and performance, and then referring for further care if needed. And then thank the patient for being open and honest, and make sure you encourage any protective practices that they're already using, and then give positive feedback about their prevention methods and those that they are willing to use or able to use. And then other P's, problems. How is your sex life going? What concerns do you have? Pleasure. Are you having any difficulties at all? With your sex life? Pride. Do you get any support from your friends and family around your gender identity? Those are all kind of additional P's that you can add onto your standardized questioning. But the biggest thing is just starting somewhere. So if you're going to ask any question, I would start by saying, I offer STI testing to all of my patients, starting there. Because you're rarely going to get people saying no, and that can also kind of open up further discussion. And then after that, if you start feeling more comfortable asking these questions, you don't have to, like I said, do this whole laundry list in one visit. You don't have to get so stuck in your head about asking the right questions and the most sensitive questions. Just kind of, first find out if they're sexually active, figure out what that means to them, because sometimes being sexually active doesn't include oral sex or doesn't include anal sex, but those are also types of sex too, and those also warrant STI testing. So clarify that, ask if they have more than one partner, and then the conversation can kind of keep growing from there. But that's at least a starting point. These are all my resources. And then we can have, we can talk if anybody else has some tidbits or strategies that they want to discuss. But I think some other resources that are not on here. These are the ones that I used in my PowerPoint, plus the ones that I referenced in the earlier slides. But National Coalition for Sexual Health is another good resource. They have a lot of patient-forward material. There's also the National STI Curriculum Trainings. And so they have a sexual health history training. They also have trainings on like specific STIs, but you do get CEs with those, and they're self-guided trainings, or you can sign up for webinars. CDC, I said they did a renovation in their recent treatment guidelines that focuses more on that goal setting. And then the American Sexual Health Association also has good patient-forward material. So hopefully those are some resources for you all.